the uptake for women identified to be at increased risk for chromosome abnormalities. The uptake pre-NIPT was in the range of between 30 and 50%. So women would come in with either an abnormal sequential or quad, or even just an increased risk by first trimester screening. And up to half of women would utilize diagnostic testing, which was really all there was, meaning amnio or potentially CBS. And the other more than half of women wouldn't do anything. They would have an ultrasound, obviously, to look for minor, major markers, but wouldn't go any further. What they found in the first year after NIPT is that the number of women declining any further testing dropped from 53% to 21%. But the additional testing that was requested was NIPT in the overwhelming number of instances. And in fact, the uptake for invasive procedures fell from 53 to 40%, and that in AMA women, and overall from 47 to 39%. So what seems to be consistently found is that the availability of NIPT is leading to more testing in women who are identified to be screen positive by conventional methods, but a decline in invasive testing. And the authors feel that this is not a bad thing because, so obviously when we look at cost, the cost analysis is tricky because of course you do have fewer procedures, but in fact NIPT, at least at current charge rates, is more expensive than an amnio and a karyotype. So depending on how reimbursement is ultimately falls out for these different things, the cost of healthcare may go up. The benefit purported by this group, the number of women who are able to achieve some reassurance from a negative NIPT. Yep.
Because their population there is a bit skewed compared to what we're going to see.
Yep.
One, Caucasian and Asian,
yep.
And given those top two medical centers,
right.
They're educated.
Right. But so far, there's several groups that have published this in various forums, and that's pretty consistent across the board that, I think everybody recognizes that screening is dropping invasive procedure. That's my next article. But NIPT is going to be like the nail in the coffin. So I'm going to circulate these articles. So this is out from Salt Lake City, and looking at not NIPT, but looking at first trimester screening and the uptake of genetic amniocentesis. And this group introduced first trimester screening in 2004, and they evaluated their data from 2003 to 2011. And the blue curve is the number of genetic amniocenteses being done in their center, and the red curve is the uptake for first trimester aneuploidy screening using NT and serum. And then when they broke it down into 3-year intervals, the average annual volume of genetic amniocentesis dropped by 2/3 almost with the advent of first trimester screening. And the assumption is that we're going to see a further major decline in uptake of diagnostic testing with the additional NIPT in the armamentarium. And one of the things that this really impacts is training. And this is the next article. Of course, there are fewer lung maturity amniocenteses being done due to the recommendation that we avoid non-medically indicated delivery before 39 weeks. And in addition, with fewer genetic amniocenteses, the ability to train MFM fellows, let alone OBGYN residents, is becoming more and more limited. So what I thought was really cool about this was that they reviewed available simulators for amniocentesis and procedures. And I've got to tell you, I love this, and I think this would be easy to do in my own kitchen if I had an ultrasound machine. And it gives you the recipe for how to make a jelly belly. And you put little balloons into it, and they even tell you how to make it so you can't see inside. And I guess if you mix orange and grape jello, it becomes black. Happy Halloween. And honestly, when you look at this ultrasound picture, and this article was from 1998, so in fact, that's an older machine. That's pretty darn good. I would be interested in in making a few of these.
I think Tim has it.
Does he?
Almost
Okay.
every ACOG meeting we've got the standardized. We've got it down to a little recipe how we do it, and we use it on every meeting. So.
Okay, well, I'm obviously so far out of date, it's not even funny. So keep doing what you're doing, okay? But I think we should do it here. I think that it would be a good thing to do here, and we can make little balloons and big balloons, and so there are some other options. I personally didn't want to use a frozen formalin preserved pig uterus with piglets in it. I really didn't want to do it, although it quote enjoys the advantage of being able to simulate more real-life situations, including poly, oligo, and anhydramnios, varied fetal pig positions, and different thicknesses of subcutaneous tissue. I would choose not to do that. And then this was really cool. This was another simulator that really looks even more lifelike from the inside and the outside. And I don't know if you do this at ACOG, but I like what I like about this particular publication. This came out of the University of Toronto, which is of course why I like it. But they had a real woman present, and they actually evaluated the trainee not only in their technical ability to produce the procedure, but they had a standardized checklist for counseling the patient and the physician-patient interaction before the procedure. So I thought really kind of a nice sort of holistic approach to teaching invasive prenatal diagnosis. And I don't know, so I would, I think it'd be fun to look at something like this and I think the idea of not just evaluating the trainee on their technique, but also their approach to the patient is actually really important. And because women having invasive prenatal diagnosis are usually pretty anxious. The jelly quivers a lot. So I thought that was a really cool article, and it was as much cool because of the historical stuff and the recipe for a jelly belly.
We'll also do it. Albeit you have to be, depending on your background and community. Some people go to Planned Parenthood and do these doctors.
Yeah, and I personally, been to Planned Parenthood to teach CVS. We started doing that at WashU before I left, and actually, it worked very well. Tracy, did you and I were there together? I think. Sorry. I had a flashback there. So yeah, but I like the idea of it being right in your own backyard, and you can do it. It's easy to do, and right. So this is another quick article from June 2013, and of course we continue to see patients who are having vitamin D levels measured and being placed on supplemental vitamin D. This is a pretty amazing study from the UK, where they followed almost 4,000 mother-child pairs and collected a lot of data about them, including maternal vitamin D levels, which were measured once during pregnancy, not specific to trimester, so it could have been in any trimester. But the children all went bone mineral density assessment between the age of 9 and 11. And they tried to correlate bone mineral density with maternal vitamin D levels in pregnancy, and they corrected for the season and boys and girls and how old they were in that 9 to 11 window. And in fact, they found no relationship between maternal vitamin D levels and bone density as measured between 9 and 11. So I like when they publish negative studies, because I feel under pressure sometimes to really be, why aren't you measuring my vitamin D level? But this was I think a nice study.
The maternal vitamin D levels were normal to start.
No.
How low? Which patients were they looking at?
It was a cohort study, and so there were patients with low vitamin D levels, normal vitamin D levels, and high vitamin D levels, and they just correlated those during pregnancy with the kid's bone mineral density. So it wasn't an intervention, it was observational. But the mothers with the low vitamin D levels, kids had the same bone mineral density as the mothers who had normal vitamin D levels. Because one of the concerns has been raised that if the mother's vitamin D is low, that the fetus is going to not sufficiently lay down bone prenatally.
I think in our case, we've got a lot of cases with gastric bypass with their vitamin D levels. I'm sure that subgroup would be different compared to.
Yes, and actually, probably even more important with them is folate. I didn't bring the case report, but there's a nice article that looks at neural tube defects in women who've had, gastric bariatric surgery. Sorry, I'll find that vitamin D article. I screwed up the order here in my slides, and I apologize for that. Oh, here it is. So next is also from prenatal diagnosis, and this is interesting, not because it's a huge study, but it's a case report of a 39-year-old woman who'd had a prior SAB, SABs, one of which was ascribed to cervical insufficiency. She had first trimester screening for Down syndrome, which revised risk to 1 in 14. She didn't have an invasive test because she was worried about loss, had a cerclage, and had a follow-up part 2, which increased her risk to 1 in 5. So she was offered an IPT. Honestly, let's not go there right now, but she had an ultrasound that was normal, okay, and she had the NIPT. So as some of you probably know, laboratories that are doing cell-free fetal DNA analysis are looking at a whole lot more than chromosomes 13, 18, 21, X, and Y. They're just not telling you about it. Okay? And if they find something that is clinically significant, sometimes the genetic counselor is getting a phone call, and we currently have a case that's exactly like that. This was from China, but what happened was the NIPT was reported as negative, but they called the practitioner and said, we think that the fetus has trisomy 22. So probably nobody here knows what trisomy 22 looks like because it doesn't survive. And with a normal growth and normal morphology, it sounds like they told the patient, look, it's very unlikely this baby has trisomy 22. So she still didn't have follow-up testing, okay? She was followed closely, and the baby developed IUGR in the 3rd trimester. She was delivered at term. Baby weighed about 6 pounds. And they did cord blood. Again, they did a microarray instead of a karyotype. So they didn't find any evidence of trisomy 22. But microarray is not great for detecting low-level mosaicism. Growing cells is better for that. So could argue they didn't do the best test to make sure that the baby couldn't have some mosaicism for trisomy 22, which has been reported, but they did 3 placental biopsies, all positive for trisomy 22. So, we know confined placental mosaicism exists in about, we think, 1% of all pregnancies. Because the source of the fetal DNA in maternal circulation is believed to be placental in origin from programmed cell death, one positive cause or etiology for a positive NIPT is placental mosaicism. And not only for non-viable trisomies, but potentially for viable trisomies 21, 13, 18. And those are very difficult from a counseling perspective. Sorry, I'm going to go back. So I think it's important to keep this in mind. It has been raised by several authors whether the appropriate follow-up test for NIPT is CBS, or in fact, should we be doing an amniocentesis for these women to avoid the potential for a confounder of confined placental mosaicism. But on the other hand, knowing about confined placental mosaicism is often helpful. Pregnancies where there are aneuploid cells in the placenta are at increased risk for increased growth restriction for 2 main reasons. One is potential uteroplacental insufficiency. The other is an intrinsic fetal abnormality. And we know that placental mosaicism for trisomy, the etiology for that is often trisomy rescue, which can lead to uniparental disomy, meaning a fetus starts out trisomic, and in early mitotic cell division, one of those 3 chromosomes gets kicked out. And most trisomies are maternal in origin. So when that second error occurs in early cell division, you could lose the paternal chromosome, in which case you'd have 2 maternal copies. And we know that if you have 2 maternal copies for chromosome 15, for example, you have Prader-Willi syndrome. And that's something that's unlikely to be detected by prenatal diagnosis. But if you know a woman has placental mosaicism for trisomy 15, she's offered UPD studies on amniocentesis. So, there are pluses and minuses to knowing about mosaicism in the placenta, but I wanted to bring this article because I think it's something we need to think about as we gain more experience with NIPT. This is a great review article on Noonan's, I think Noonan syndrome, it's estimated that when we look at a cohort of fetuses with elevated nuchal translucency in the first trimester, about 2 to 3% will have Noonan's. It's sort of an easy way to think about Noonan's is it's the Turner syndrome that doesn't discriminate on gender. And the lesions cardiac lesions tend to be right-sided versus left-sided. What I really like was this gorgeous photo grouping of 5 generations of Noonan syndrome, just the variable facial features across this family, 5-generation family, where it's the same mutation that's segregating in the family. It's a very nice example of variable expressivity of a single gene mutation. I thought that was really cool. I'm starting to sound like Miley Cyrus from Saturday Night Live, and it's really cool. So next is something I'm very interested in, and I think we should pursue the utilization of what's called a post-mortem minimally invasive MRI versus conventional autopsy. And this is a nice study also out of the UK with good people. Sabir and Chitty were co-authors. They did a prospective study in over 400 cases where families consented to conventional autopsy and were also consented to MRI. The MRIs were done, they mainly used T2 weighted images. I'm not exactly clear on why it took about 90 minutes to do the scan in fetuses. I'm assuming it was kind of quality control for imaging as they went along, because obviously movement wasn't a problem. So longer acquisition time as well. But, and it's important to know that because they were usually done at night. So it was great because it didn't interrupt the scanning schedule during the day. So as long as it didn't require quality control by a physician, it could conceivably be done by a tech at night under protocol, and not have any downtime to the machine, which in terms of cost is one of the definite costs if they can't do a paying patient. So it also included children. This was a really detailed study. They did a sort of a pre-analysis. It involved neonatologists, MFMs, and pediatric pathologists, all of whom had a minimum of 8 years of experience. And they outlined a list of anomalies that they thought should be detectable by the postmortem MRI because they recognized that there are certain things that are just hard to see. They basically did include postmortem blood sampling via needle puncture. So, because obviously one of the things that you can't do with an MRI is get tissue for karyotype, infectious studies, etc. What they found, they looked at 423 cases. Their first 20 cases were quality control, so they didn't analyze those. And then they looked at the correlation between conventional autopsy, and the MRI. And they actually found that there was extremely good concordance. In fact, the same diagnosis was achieved in 90% of MRI conventional. What was, I think, even more interesting was that for neuropath, there was a suggestion that the MRI may actually be better. And we know that neuropath is notoriously difficult because the brain becomes rapidly autolyzed. And in 43 of the cases, so 10% of the cases, the brain was non-diagnostic conventionally. But in 30% of those brains, they found a clinically significant anomaly in the MRI. Now, obviously, they couldn't confirm it, but we think MRI is a pretty good imaging modality for the brain. In fact, it's one of the main indications for prenatal MRI are subtle CNS abnormalities that we don't see with ultrasound. So I thought that was interesting. And when they looked at their predefined criteria of what should be detectable with the minimally invasive autopsy, there was 99% concordance. So they actually outlined a group of anomalies that they felt should be detectable by postmortem MRI, and they agreed with it. So particularly in centers with low autopsy rate, and I think we have a relatively low autopsy rate. I know I personally have a low autopsy rate, despite what I know is a hard sell. I mean, I really try. I think this might be something that is acceptable to patients, and there are some other articles looking at sort of acceptability, which suggests that they may be willing to undergo this. I think this might be a good option for some of our patients.
You're doing it at Children's.
Great.
They're studying.
Yeah.
A lot of money.
Yep.
For the query of perhaps metabolic disorders and that's
Uh-huh.
special settings other than really look for metabolites. We can set the menu. So if you have a product used by metabolic
the other thing that we might be able to sell to families is urine and blood collection, and I think that whole thing of tissue collection tends to get lumped in with a conventional autopsy, but families might be willing, and urine is one of the best methods to look for metabolic disorders. So we might be able to get families, who would agree to a bladder tap and a blood collection. This is just an interest article.
Prior to delivery or after?
Post. Well,
just do the bladder test.
I love doing it before, but when she gets her epidural. this is just a nice kind of point counterpoint written by Mark Johnson and Doug Wilson. What I hadn't seen, the other reason, it's just interesting to read in terms of counseling patients about prenatal MMC repair. But what I also really liked was he referenced this article that I didn't see, looking at reproductive outcomes in subsequent pregnancies. And it was an update of their experience of subsequent pregnancies in women who've had open fetal surgery, not necessarily MMC. And the dehiscence rate was 14%. The rupture rate was 14%. And just highlighting that guidelines are elective delivery, 36 weeks, no lung maturity amnio, and a minimum of 18 to 24 months between pregnancies. So I'm going to go over to the twin article. John Barrett, yes, sorry. Yeah, go for it.
Rupture rate is that
uterine, no maternal or fetal deaths. 1 C-hist out of 36 mothers. You know what? I kind of skimmed it, but I'll send you the reference. I saved it, but it's kind of a spotty article. There's not a lot of the juicy details weren't there in terms of in labor, not in labor. I mean, definitely there were patients in the study that had gone farther than 36 weeks, and it's a descriptive study. But just in terms of talking to patients about next pregnancies.
Was preceded in some cases. So it's a hodgepodge.
Right.
Yeah, reporting bias that the patient's lost.
Right. But we don't know. Bottom line is we don't know. And the other thing is that I think they only had a 50% follow-up rate in the cohort. And I think we assume that if something bad happens to somebody, we hear about it. In fact, there's good literature to say that we don't hear about it when bad things happen. But a counterpoint to that is that 95% of the women who participated in the follow-up said that if they had to do it again, they would do it again.
And this is the pre-mom's era. This is the mom's patients, right?
These are well, this is CHOPS. This is CHOPS data.
So 2010, so patients up in 2005.
Up until 7.
Yeah. And it wasn't just MMC. It might have been a teratoma. It was anyone having open fetal surgery that was a candidate. I don't know.
So there's clubs in the exits too. Then.
It's anybody with a non-traditional incision. But these patients were delivered. These patients almost all have 2 uterine incisions, right? Because they have a low transverse for their C-section plus whatever their uterine incision was for their open procedure. Pardon? Yeah, I'll send that. I will send that attachment with the pre-post moms. So onto the feature. How am I doing? It bugs me. There's no clock in here. It's 8:15. So this is I think a great undertaking by this group. It is a randomized trial of planned vaginal versus planned cesarean delivery for twin pregnancies, randomized between 32 and 0 and 38 and 6. In order to be included in the study, women had to have a cephalic first twin with estimated fetal weights of both fetuses between 1,500 and 4,000 grams. So really a pretty broad inclusion criteria. And the exclusion criteria are less stringent than I would have probably had. Monoamniotic twins were excluded. You couldn't have had a fetal reduction beyond 13 weeks. I'm not exactly sure what that was about, but you couldn't have had, no, I'm just not sure why, but probably because you would increase risk for preterm birth anyway, but prematurity wasn't what they were getting at. But but I guess it's important in the analysis, so I can come back to that. You couldn't have a fetus with a lethal anomaly, and you couldn't have a contraindication to a vaginal delivery. So that was obviously fetal compromise. This is important and something I talk about with the residents. First twin larger than the second. We tend to get very concerned when the second twin is bigger than the first. But in fact, when you're considering the option of a breech extraction, a pedalic version with the potential for interval delay or ruptured membrane, prolapse cord, abruption, if the second twin is significantly smaller, it raises the potential that that fetus, in fact, may have some underlying uteroplacental insufficiency, and so may well not tolerate the added time associated with a vaginal delivery. And again, if the fetus had a big Goomba hanging out somewhere, they wouldn't do it. You could have one prior cesarean section, but it had to be a low transverse. So multiple C-sections or prior classical. Women were randomized. There was central randomization. They were stratified according to parity, and also by 2-week gestational age intervals. So the randomization was done in blocks so that parity and gestational age wouldn't be confounders. Interesting, the surveillance was a, quote, minimal of fetal growth and well-being by ultrasound at least every 4 weeks. And then the option of additional surveillance if needed, which was unspecified. In order to participate, and this was a worldwide study, you had to be able to do a C-section within 30 minutes, and you had to have anesthesia nurses and a doctor available in the hospital at the time of a planned vaginal birth. The sort of the plan was for elective delivery between 37 and 5 and 38 and 6. If by chance you delivered your first baby vaginally, but you were in the planned C-section group, you were supposed to try to section the second twin. So yeah, I kind of thought that was interesting. And as a patient, you're gonna what? Like one baby just fell out, and now you're gonna crash me for the second baby because. But I thought that was intention to treat, and you were supposed to treat. I think there was only 1 or 2 babies that actually were in that category. They expected a 60% vaginal delivery for both twins in the planned vaginal delivery group. So in their power calculation, that was what they were using. And you were allowed to induce twins, but if they'd had a prior C-section, you couldn't ripen the cervix with prostaglandin. In terms of management of the second twin in the planned vaginal delivery group, they encouraged you to use ultrasound in the delivery room to assess the presentation of the second twin, but you didn't have to. If the second twin was cephalic, you were encouraged to allow labor to progress normally, so not to intervene, but to wait for the head to descend and rupture membranes once you had descended the head. No time specified, but with continuous, obviously, fetal heart rate monitoring. And if you had a non-cephalic twin, it was left to the discretion of the delivering OB. So you could basically do whatever you wanted. You could do an internal patalic version, you could convert it to cephalic, you could take it out as a breech, you could section it. The choice of practitioner was interesting. They recruited, and I don't know how they did it, but an OB who wanted to participate in the study told them they were experienced at vaginal twin delivery. And your department head then had to agree with your self-assessment that in fact, so if I wanted to be in the study, I guess Dr. Gross or Dr. Artal would have to say, yes, that's right, Kim is experienced at a twin vaginal delivery. I don't know how many times they said not, and somebody was declined, but it was really a self-assessment, which was kind of interesting. So that's how they tried to sort of have quality control. So their outcome measures were assessed through 28 days postpartum. I think their composite fetal neonatal mortality or morbidity outcomes were pretty severe. I think they defined them pretty significantly, and there wasn't anything on this list that I thought was kind of a soft call for calling it morbidity. Coma and stupor were probably the ones that got my attention the most. But obviously they looked at potential bad outcomes with both vaginal and cesarean births. And right, and they used 5-minute Apgar less than 4, and 5-minute Apgar less than 4 is pretty bad in a 32 or beyond weaker baby. Maternal also was pretty severe outcomes in the morbidity mortality scores. And they are planning a 2-year analysis to look at both maternal and fetal outcomes. They calculated they needed 2,800 pregnancies to detect a decrease with planned cesarean delivery from 4 to 2%, and they had an 80% power, also allowing a 10% crossover within the groups. They did do 2 interim analysis at 1,000 and 1,800 women recruitments, which allowed the study to continue for safety reasons, and they did plan subgroup analyses to test interactions with a variety of baseline variables, including the 2 things that they tried to eliminate as bias, which were gestational age and maternal parity. And they also looked at the national perinatal mortality rate in the mother's country of residence, and they stratified outcomes based on whether the country's perinatal mortality was less than 15 per thousand, was 15 per 20 per thousand, or greater than 20 per thousand. And only 2 countries with relatively small contribution were in the greater than 20 per thousand. U.S. was in the less than 15. So this slide I put up because what's really important is their outcome data was excellent. I mean, they lost only 6 women in the planned cesarean delivery group, and they lost 17 women in the planned vaginal delivery group, which out of 2,800 women is really good ascertainment. The 2 groups did not differ in any of these particular parameters, including, of course, parity and gestational age at randomization. More than two-thirds of patients were randomized before 37 weeks. Interestingly, I think was it 5% were randomized after membrane rupture, and some were even randomized. They weren't in labor, but were randomized fairly close to the time of delivery. A quarter of them were monochorionic, so I think that's a pretty good representation in the group. And I was surprised that they included monochorionics, but they did. In terms of what happened, if the plan was for a cesarean delivery, 89% delivered by cesarean both babies. There were 11 who had a vaginal for the first one and cesarean for the second, and 9%, so again that 10% crossover. Unfortunately, only 56% of the planned vaginal delivery had a vaginal delivery for both twins, and I think that was very disappointing. They had assumed 60%, but 40% were delivered cesarean for both, and 4% had a combined vaginal and cesarean delivery. I think that information is important in counseling patients. When I talk to patients about a vaginal delivery for twins, they often say, well, what's the chance I'm going to end up with a C-section for the second one? And that's often a deal breaker, ladies, if you're considering a vaginal birth. So in experienced operators' hands, the need for cesarean of 4% is, I think, would be probably acceptable for many people.
It's only those that
You're right.
Vaginally
You're right. It's about 8%. You're right. It's about 8%. Yeah. Yeah. And when you look at the timing of the C-sections, most were done before labor. In the planned cesarean delivery group, fortunately, most were done during labor in the planned vaginal delivery group, which is, I think, good that they weren't electively sectioned. And there were, a not insignificant 3% of the first twins were non-cephalic at the time of presentation. So about what you'd expect. Some differences in outcomes. One was that the timing from randomization of delivery to the first twin to delivery was shorter in the planned C-section versus planned vaginal delivery. I think probably reflecting the fact that for practitioners, if they're planning a cesarean delivery, they would ideally schedule it a little sooner than later to avoid the labor in the middle of the night, get me out of my bed on the weekend kind of possibility. And in fact, the authors state that this is one of the potential advantages of planning a vaginal delivery is that iatrogenic late or early term birth is currently something we're trying to eliminate, and that with planned cesarean delivery there was a higher rate of early term delivery compared to the planned vaginal group. Yep.
That's statistically significant. I get it, but it's 0.9 days.
Well, good question. And what's interesting is that in fact a difference of 1 day in the gestational age of delivery is different. I don't know. We certainly are stratifying management currently based on a 1% difference in NICU admission.
But, when they look at the data by gestational age, they don't go by the 38 weeks and 6 days is considered the same as 38 weeks and 0 days. They go by completed weeks, so that's how the longer term data assess the completed weeks.
Well, and they state that they're going to look at, and they state that they're going to they want to specifically look at 1 week increments, particularly in that 37 and 0 to 38 and 6, which addresses that issue of early term birth. From a fetal neonatal death or serious morbidity, I think the important thing is that they found no difference between the planned cesarean and planned vaginal delivery group. And that was still true regardless of gestational age at delivery. And similarly with the maternal death or serious morbidity, they were disappointed actually that there wasn't a difference, and they suggested that perhaps this was because of the relatively high cesarean delivery rate in the planned vaginal delivery group. And women in the planned vaginal delivery group, of course, were exposed to more types of morbidity than women who had a primary cesarean section, because they had the potential to have had a perineal injury, and then if you section them, you then have an increased rate of morbidity. And also, we know that morbidity is higher with emergent versus pre-labor cesarean section. So the type of cesarean section women in the planned vaginal delivery group may have had probably placed them at a higher risk for morbidity and mortality. But it wasn't significant. In terms of the subgroup analysis, there was no significant interactions based on chorionicity, presentation of second twin, or the country that you were born in. The second twin was more likely than the first twin to have one of the adverse primary outcomes, which has been reported in other studies with an odds ratio of 1.9. But that held true whether you were born vaginally or you were born by cesarean section. Correct. That or unpreventable. The unpreventable morbidity.
Was it analyzed based on intention to treat or actual rapid delivery?
I think they were all intention to treat. but I'm not 100% sure. I'd have to go back and look at that specifically. They concluded that a planned cesarean section did not reduce the risk of fetal or neonatal death or serious maternal morbidity mortality compared with a planned vaginal birth. That there was a higher risk of adverse perinatal outcome, but planning a cesarean delivery did not reduce that. Obviously, there are some strengths of the study, which are it's a randomized design, the central randomization. It was a huge study, which I'm sure will never be done again, and they had a very high rate of follow-up, very little loss to follow-up in the groups. So I thought it was a great study, a good study, and I think it provides good descriptive data of what happened to both groups for counseling patients, and I think it is support for a practitioner who feels that they are experienced in vaginal twin delivery to support planned vaginal birth in twins beyond 32 weeks.
Any comment on how many people they approached for the study that sort of defined the study? Because I didn't see that. I just kind of assumed people didn't want to participate for whatever reason.
Let's see.
They don't want to be.
It just said they enrolled.
Yeah.
So yeah, I didn't see that either. And I tried to get the supplementary appendix and I couldn't find it. Anybody else have comments about the study? I mean, anybody? Yes. Yes.
As a self-proclaimed expert in vaginal delivery,
Yes.
I'm not sure what the term is.
I'm sure he'd say go for it.
I suppose the study was very good on its broadness. However, looking at the vaginal delivery group, 40% section was 60% or so success, 56% success rate on planned vaginal delivery twins at term with all of the movement period except the one monologue. To me, that's indicative of accuracy skills at vaginal delivery. When I talk to the residents, the people in the city, perhaps outside this institution, and have that skill set for vaginal delivery and lay utilize. They certainly do more than anybody else. So we're both the experts in aesthetics and gynecology, but we do have, speaking broadly, the expert skill set to provide vaginal delivery in certain circumstances. It's common in the athletic translation. But this is saying what's happening in our planet today with respect to twin delivery, vaginal delivery. No.
A quarter were monochromatic.
Well, I think this is just the full attention.
Right. Correct. Well, so I have anecdotal information that in Canada breaches are coming back. They don't believe. Right. Tracy.
I was just curious why they included so many prematurity related conditions in their composite, and why did they set the bar so high or so low? They seem to be, and how you look at it in terms of the FR score.
So I don't know why they sort of did what they did. 95% of patients actually delivered beyond 34 weeks. So in fact, the sort of serious prematurity outcomes should have been pretty rare in both groups, right? When I looked at the composite morbidity, I mean, I thought that they were things that would be pretty rare in most babies born beyond 32 weeks. I mean, and the fact that 95% were born beyond 34. So I thought they were good surrogates for potential intrapartum problems, as opposed to prematurity-related problems.
I would echo that. I think you want to look for significant morbidities, not the second when you have half part 6 who perked up by 10 minutes of life. Really looking for problems that are going to stay with the baby.
I mean, I give them credit for actually looking at morbidities that were actually morbidities, because I think some studies get a little soft call on their morbidities to see significance, and that ends up tying our hands because they want to find a difference and. Right. Exactly. Yeah. Exactly.
I did a very random run of the book with this article of mine, just to say with respect to twins. At our institution, this is looking at the last 4 months, so very short, but just put up with bam. Where can I find them? And excluding pre-viable twins, of which there were unfortunately a number. We have about a 40% vaginal delivery. That was a quick analysis on back up. Since this was done more of a to an institutional say how is it being practiced.
Yeah, I think that breech extraction is something that you can practice, and you can practice it at the time of cesarean section. And I hate cephalic second twins. That's my worst thing, because I cannot grab a head, and that's just the way it is. So pardon me?
You still do a breech extraction.
Correct. So I think, if particularly those of us who are comfortable with internal version breech extraction, I think doing it at the time of delivery is, if you have intact membranes on a second twin and you don't have, an obvious contraindication, it's a good time to practice when you actually have, potentially a little more control.
Sometimes the most experienced person in the room is the one who's at the bottom of the ultrasound machine. It's not digress that machine.
Well,
To
yeah, personally, I think that because time is such an issue, and I think a lot of the data that suggests that the poor outcome for the second twin with increasing interval between delivery reflects misadventures trying to deliver the second twin. Personally, I don't really use the ultrasound. You have a 4 to 5 minute window before the uterus contracts again after the delivery of the first twin, and you really have to be able to find feet. That's just and the kid's moving, kicking. But the heart rate, sure, but heart rate is.
When there is a problem with the second twin.
Heart rate is absolutely what you're using with ultrasound, but what I think people think they're using the ultrasound for is to find the feet. And finding the heart rate doesn't require a great deal of experience. Finding the feet does, and not pulling down a hand. And finding feet and hanging onto them while you're trying to get the membrane structure does.
There was a nice review on twin delivery in 2011, which is great. And one of my favorite studies was by Groff, way back in 1989, where vaginal breech dose were higher than they are today. And in their study, they showed of 136 sets of vertex, non-vertex twins, specifically looking at non-vertex twins. If internal clodalic version of breech extraction was performed as the first attempt, vaginal delivery was successful 96% of the time. When ECD was performed as the primary delivery attempt, successful vaginal delivery occurred only in 46%. So this is our literature, and this is a repeat study that has been reported since we started writing about it. very different animal than Vertex versus Vertex non-Vertex. Yes, very different.
Only ones I've sectioned were Vertex.
However,
only second twins I've sectioned. Yes. Yep.
So I read the article a while ago. The reason for the 40% section rate on both twins, did they go into that?
I don't. Yeah, it was at discretion. I mean, a small number were because of non-Vertex at presentation, and I'm trying to. I'm sorry. I don't think they really specified clearly why. Some of it was because there wasn't an experienced practitioner. So not all practitioners in every center were participating in the study. So I know that was some of it. What else did they say?
That seemed to be the
right. That was the question. That was, I think, I didn't put it in because I think I didn't find it, like why they sectioned it. Yeah. I mean, it was probably physician discretion.
Yeah, I mean, because I'm what was
or it could be fetal intolerance to labor.
Was there CPD? I mean, that's the part that I would be interested in seeing. That's fine.
Right.
Did the patient change or not?
Right. Definitely, it's not spelled out. They didn't break down all the indications. Maybe that's coming. I don't know.
If the patient changed their mind, they still be included in the study, or maybe if they were randomized to certain approach and they decided, I don't know,
they said they included all enrolled patients and as intention to treat. So who knows? Maybe some of the vaginal deliveries were women who were randomized to plan cesarean and didn't want it. That's potentially. They don't spell it out as it was intention to treat for both groups. Yeah. Well, thanks everybody. Okay.
PDF set up as well.
Pardon?
PDF.
I have all them PDFs.
Can we hang on to the PDFs? Yeah, right there. Do you know which or would you send them out later?
No, I have them. Where do you want me to share them?
You just put them on the. We'll make a folder. We'll just upload it. I'll see afterwards. You had it. Go in the start. Go to the start menu, which you just clicked on. Go to the computer.
Yes. Okay.
So I don't think you're going to
Do you use EndNote?
Okay.
I think one of them might be any company.
ability to judge.
Right. Well, yeah, they're looking at everything.
I'll fix it. The folder is behind your screen.
Where? Oh, that was the presentation.
Do you use EndNote much?
What?
EndNote?
Obviously not.
Okay, so when you use EndNote, it sort of organizes all your articles for you and lists them the way it's supposed to be listed. The official.
Oh, the actual title.
So it's listed the right way. And all you do is it's free for sleuth people for about 2 years. All you do is just drag and drop it in there. You organize it by year, by name, author, everything. So and it saves it into a portfolio for you that you can access from anywhere. Say you get the talk today, you want to look at it 10 years from now. Say K1 Jacob 2013. So not only does it give you the articles from there, if there are any updates to it, it keeps updating it for you automatically. Plus, if you wrote a paper, it would just cite it for you from that database.
So they aren't all there, but some of them are actually on my laptop. I had 2 folders going, but I'll get them all to I'll get them all to Morgan the second I'm in.
Do you have more?
Huh?
Do you have more? Anything else?